I'm hoping maybe we just misunderstood. Is my hope is that maybe there's some other reason for this. I don't think there was because I just again the 30 days thing makes no sense.
It's the craziest thing I think I've seen or I've heard anybody stay in a public space. Hello, everyone. Welcome to the TRT and Hormone Optimization YouTube channel. Once again, Danny Bossa, and joined with my esteemed, super cool guest, Dr. Jordan Grant. How you doing, Jordan?
Good. How are you, Danny?
Awesome. Today's video, I had the pleasure, if you want to call it that, of listening to a particular podcast that was done on Ben Greenfield's show. No disrespect to Ben Greenfield. He's a great podcaster. But there was a guest that he had on that discussed TRT. And I got sent the link by probably 25 or 30 different people saying, have you heard this? And have you heard this? And you got to listen to it. You got to listen to it. I'm not super familiar with Ben Greenfield's work. I've listened to a few podcasts. I have watched him on Joe Rogan Experience. He clearly knows his stuff. So I went and I listened to this podcast with, try to get an open mind to see what this person's saying. And, sometimes there's always something you can learn. It just seemed that more than half, and I think I'm even being conservative there, probably 3/4 of it was not just untrue, it was demonstrably wrong. Like literally demonstrably wrong. I brought it up to Ben. I was looking into it, and there was a bunch of comments that were appearing on the podcast of people challenging what was being said there. I had made up a couple of key points, and I thought maybe it would be good just to make a video about what these key points were and why I felt they were demonstrably wrong. And who better to help me explain with Dr. Jordan Grant. So, Jordan, I basically... I think you listened to, you saw the transcripts of some of that podcast. I made a few key points of things I wanted to address. So I'm going to read you out what some of these key points are. And then we can each I can give my opinion. Again, it's just opinion that I have. I'm not a doctor. I'm not a physician. I do deal with a ton of guys. I see this all day long now. It's for quite some time. So I think my opinion is, I can almost say a pretty educated perspective at this point. And then you can maybe talk about if these are things that you're seeing in your practice with your experience.
Sure.
And go from there. So right up at the beginning, the guest was discussing how he claimed, he was giving a list of the blood work that they do. And he says, we test total testosterone, we test HCG and whatever. And he was making it sound that total was the key marker in evaluating a patient's blood work. Immediately after he said that, Ben Greenfield, again, brilliant guy, knows his stuff, chimed in and says, what about free testosterone? I was under the impression that free testosterone was kind of the one you look at. And he says, we kind of use total, but then we'll use SHBG, and then we can kind of get an idea what free is, but those are the ones that we use. In my opinion, and I guess you can, chime in there, is it's just not done anymore. We're really just focused on the free. Total testosterone is all test, be it to the free, be it bound to SHBG, be it bound to albumin. And the part that is really going to have an effect in the body is the part that is free, the part that is unbound. To base somebody's labs on their total is just not done, because you can have a guy who's got total T of 1200 and his free T is 35, and you can have another guy with total T of 1200 and his free T is 12. Their totals are going to be the same, but I can assure you the guy with free T of 25 is going to feel a hell of a lot better than the guy with the lower amount. We don't really use total testosterone anymore. We really just focus on free, on getting those free T levels up. To me, the other ones are pretty much irrelevant. What are your thoughts on that, Jordan?
So I will say that he's not outside of the mainstream with what he's saying as far as still following endocrine society guidelines. And so it's not that he's necessarily doing something wrong. He's doing what most do, which we try not to fall in lockstep with a lot of the outdated guidelines. And I think there is a place for, like you say, free tends to matter just as much as total. I do think there's a place for total. And the reason I say that is if you had nothing but free testosterone and that was all you had, you would not feel great. You'd be a hyper excreter. You wouldn't be able to, you'd either be going crazy or you'd probably just not use it. And that's the issue we see with these really low SHBG guys like the diabetics. They become what's called hyper excreters, and they're not getting the most bang for their buck from their testosterone. So SHBG does have a place and kind of a buffer system to act as a time release. You need both, and so I would say that free testosterone is also necessary to relieve symptoms. And I don't know that, we were taught in residency not to check it and that it didn't matter. And so, like I say, he's not going against the grain with that, but I do think it's not ideal. I think since I've started checking free testosterone in guys that are symptomatic, it's opened up a big world to me as far as understanding, hey, now I kind of get more, and not that numbers matter anyway. Symptoms should matter no matter what. But most of these guys that come in and their T is 500, 700, I had a guy that was 900. Their free T is like 7, 6, 5, low. I mean, really low, and we're treating up to free T to 25 to 40 nanograms per deciliter on a lot of these guys, or 20 to 40, somewhere in that range, usually over 20 before they really feel well. And so I do think testing the free T has a role. I think maybe a lot of people don't realize that you can check that in an actual accurate way. You don't have to calculate it. You can send it for equilibrium dialysis or ultrafiltration. There's still maybe some issues with checking that. It's not always a perfect lab. That's the same with testosterone in any lab. There's always issues. So we do need to go off symptoms as well. But I definitely hope they're not. I would hope they would maybe look into the free testosterone side of things, because they might end up helping a lot more people than just basing it off a total. But maybe they're treating people based off symptoms too, and we don't know it. Maybe they're just using that total as a guideline. I don't know. So I'm not going to speak for them, but I will just say that unfortunately what they're doing is very much the norm as far as most clinics go. And if they're following the Endocrine Society guidelines or even the AUA guidelines, they talk about a, total testosterone less than 300 on 2 different occasions, blah, blah, blah. Thankfully, that was questioned recently. Dr. Morgenthaler wrote a response to the AUA guidelines questioning some of that, and because he believes, I think, more in symptom resolution and symptoms. And so I think down the road that'll change. But yeah, I agree with you for the most part. I do think total has a role, but you need both. And so you can't base much off of just a total testosterone. Yeah, I agree.
Another point he made is he was saying how he cycles off testosterone every 6 months. He takes a whole month to let his body reset. How about you start with that one, and I'll give you my opinion.
I've heard this before from random places. I've seen it in bodybuilding forums. I think there's a couple doctors that were doing like a restart twice a year. There was maybe a doctor in Houston that was doing this, where he just like all of a sudden stop TRT and give guys HCG for a month and get them back. It's not physiologic. It's not warranted. There's no reason for it. There's no receptor burnout. There's no the stuff people come up with. And I don't know what his philosophy is of why to do this. I didn't really understand it. I know he kind of mentioned it, but I didn't really think it was a good explanation of why. And so maybe if he's got a good reason, but I can't see a good reason, especially 30 days. That's not even enough time for your system to reset. I mean, it can take people sometimes up to a year to recover, if ever. You're not likely to. And why put your body through 30 days of hell? And if you need testosterone, you need testosterone. That's the whole reason you're getting it, because you were low. Mm-hmm. You're actually worsening your chances at recovering the longer you're on testosterone. So that's my opinion on that. I don't think that's a common practice. I will see some really poorly educated doctors, a lot of endocrinologists, when they get a patient that's been on testosterone, they'll say, "Oh, we got to take you off your testosterone now to get a new baseline." It's kind of the same thing. That's just stupid. I'm sorry. I'm not, I know I shouldn't say that as a doctor, but that's literally almost malpractice in my opinion. If you're taking a guy off the treatment that he clearly needs to get a new baseline, his baseline is he's low testosterone. I mean, that it just makes no sense. Just take his protocol and fix him if you're going to, but they won't. Anyway, that's similar to how I feel about that. If you're coming off and for 30 days, that's not doing any good. So
there was a guy in our Facebook group that had a new doctor and said, we're going to take you off the testosterone and get your baseline. We want to see what your numbers are. And I said, well, what do you think the numbers are going to be? Like after a month, I'll be completely suppressed. I'll have almost none.
Exactly.
And he posted before and after pictures of what he looked like on T and off, and it was like, it wasn't pretty. And it was about a 6 month, recovery.
Yes, it's horrible. I know who you're talking about. This happens to a lot of guys, and it's heartbreaking. It pisses me off. I'm going to be honest with you, because I see this in my clinic. I'll get guys, and they've been run through the ringer, taken on, taken off, put on, taken off, put through a year's worth of testing because they somehow got sent to an endocrinologist, and they're like, well, we got to get an MRI. We got to take you off this. It's like, what are you doing? I mean, this is crazy. And these guys feel like absolute death during this process. They almost become like depressed. They can become suicidal. Like, no, that's probably not going to happen with this gentleman's protocol 30 days. But it's still, there's no point in 30 days. I mean, either if you're going to come off, you come off for good. You try to restart, whatever. Like that's the whole, if you just don't want to be on testosterone. But 30 days, twice a year, it doesn't make any physiologic sense to do that.
I'm going to give the people watching this the most logical, rational, common sense explanation of why I think it is an absolutely crazy idea to do that. When you first get on TRT, what happens? It takes quite a bit of time to your body to adjust to these new levels, right? And you're dialing in your dose, and take more, take less, and your body's constantly in the state of flux. You got all these issues. Maybe you got water retention. Maybe you're getting symptoms of gyno. You're getting some ED. Oh, my libido's back. My libido's gone. You're up, you're down, you're left, you're right. And you just can't wait for your body to stabilize. Eventually, your body does stabilize, right? And once your body stabilizes, what happens? These now sufficient levels of the androgens are going to start having an effect on the body, and they're going to start making you feel better, start resolving your symptoms more and more. And as time is going to pass, you're going to continue to improve. Okay, so it's not just a matter of I'm going to take tests and I'm going to feel better tomorrow. It's I'm going to take tests, I'm going to bring up my levels, and then I got to wait it out and let those levels have an effect on the body. Okay, so it's kind of like I don't just turn on the thermostat on my wall for heat, turn it up to 30, and suddenly it's 30, right? I got to turn it up, and now I got to wait for it to do its job until I get to 30, just to use a simple analogy. So what happens now if you stop for 30 days? Your body's now used to these levels of testosterone and everything is going great. And suddenly you say, no, we're going to turn off the tap.
Especially with cream.
Especially with the cream. Your levels will tank, and they will tank fast. What happens? Your body now goes into a state of flux. Your body is now trying to figure out what the hell am I going to do here? It's rebalancing everything all over again. Okay, so you're not going to feel it right away when you stop. A week later, you might start feeling a bit off. 2 weeks later, more off. 3 weeks. Okay, now by the 4th week, like Jordan, you said, you're going to feel like death. And now what? Now I'm going to start taking my TRT again. What's going to happen? We're going to start the whole damn process over that we went through at the beginning. You're going to start it over from scratch. Okay, we're going to start from the beginning. Now we got to get those levels up. Now we're going to have the hormone fluctuations. Now we're going to have the water. We're going to have all these different things going on. And now we're going to wait till we finally start getting better. Now we're finally better. Now we got to wait for these levels to have an effect. And that whole process itself might even take you 6 months. And as soon as now you're starting to reap the benefits of testosterone, guess what? Let's not take any again. It's the craziest thing I think I've seen or I've heard anybody stay in a public space, maybe with the exception of guys that are taking multiple milligrams of aromatase inhibitors a week. That's probably my number one. But this was right up there with some of the absolutely mind-blowingly nuts thing to ever suggest anybody do. Any of you guys that are on testosterone and you've dialed in your protocol and you're feeling good and you have no symptoms, don't touch anything. Stay there. That's the whole point, is to stay there, feeling good, feeling healthy. Don't do that.
I'm hoping maybe we just misunderstood. Is my hope is that maybe there's some other reason for this. I don't think there was, because I just, again, the 30 days thing makes no sense. I'll see guys who've been pulled off their testosterone by their doctor, and it's taken them 3 or 4 weeks to get in to see me for whatever reason. They feel like crap. I mean, they do. They're like, I mean, they go, if they're on injections, they go 2 weeks without a shot. Even they're already low and they feel it. So 30 days, it's going to be miserable. Like you say, you readjust back once you start back. And with cream, it's in your system so fast. So then you're going from nothing to whoo. I mean, it's a lot. And the only way I could see that being, I mean, I don't know. Steroid users do that crap, because they'll come off because they're not feeling their drugs anymore, and then they'll come off, and then when they get back on, they like the feeling. Steroids aren't supposed to give you a feeling; they're supposed to just work. If you're doing it for feeling, you're probably getting side effects, is what you're feeling. And people tend to want to chase side effects because they feel like it's doing something. Like people take pre-workouts and all this stuff because they want to feel a certain way, even though that's not what's doing good. Is that something going on here? Maybe. I mean, are these people, I don't know. Like, do you want them to feel that rush again or that change? Like, I don't know why. I'm speculating. I have no idea. So I would love to just know more. And so, let's dive into that if the gentleman ever wanted to respond and just give us a little more rationale, because we may be missing something. So
another point he said is that he felt that TRT is not always a permanent solution. So he made it sound that guys are not doing that well. He'll put them on TRT and then get them maybe exercising, get their diet in check, and then he'll say, okay, well, let's try to get you off your TRT now. What are your thoughts on that, Jordan?
Yeah, again, that's not how it works. If you need testosterone, you need testosterone. And once you're on it for long enough, your likelihood you're going to rebound is even lower. And so it's a commitment once you start it. There are extenuating circumstances where guys have to come off. I mean, fertility issues, if HCG is not working, then they really have to come off to do some other protocols, or their doctor makes them come off, and that's fine. It is what it is. But in my mind, it's once you're on, you're on. And I tell guys that when I see them, this is a commitment. It's a big deal, and you got to be ready to do it. You got to be ready to give yourself a shot at least twice a week, or you got to be able to put cream on twice a day, or at least once a day, forever. Because a lot of them will say, how long I got to do this? They think that they're going to get their levels up and then they're good. I'm like, no, that's not how it works. This is permanent. I mean, maybe those people never needed to be on testosterone in the first place, but I think it's your responsibility if you're starting them on it and you're suppressing their natural production. It's a big deal to take them off and then deal with the repercussions of that. So I'm not, again, maybe there's something else there, because I saw that in the transcript, and maybe he meant something different is what I was saying. Maybe he meant it's not a permanent solution for their health, meaning they've got to get their life in order, or, which I agree with. I think, he did say a lot of the stuff, and I do want to make it clear, a lot of stuff he said I do agree with, like being healthy in general and taking care of yourself. It's a big deal. And he did even mention some guys need higher levels to feel better. I think it's great that he mentioned that. A lot of people do not believe that. So, I mean, that's A+ on that. But if you truly feel like you're getting somebody on testosterone and you can get them dialed in and then eventually bring them off, I don't really personally agree with that.
To me, the transcript sounded like that, and I'd love for someone to correct me if I'm wrong, or he can correct me if I'm wrong.
Absolutely.
But to any of you watching that are considering going on TRT, if a doctor's told you, oh, you only have to take this for a little while and then you can stop and you'll feel better, no. You have to say to yourself, if I'm taking this now, I'm going to make my body stop making any of what it's making naturally, and I'm going to have to rely on this exogenous testosterone for the rest of my life. So you got to put that through your head that this is going to be something you're going to do forever. Okay. For sure, if you are in poor health, maybe you were obese, you had a number of issues going on, and your testosterone levels were tanked, and then you take testosterone, and then over the course of time, you dropped 100 pounds, and you're exercising, and you're eating well, and all this type of thing, you could say, well, would my testosterone still be low today in this new state that I'm in physically? Perhaps it'd be a hell of a lot better than it was when you were obese, granted. But you have to understand that if you've now brought your levels up with testosterone, are they going to be up there? Most cases they're going to drop down. Okay. You're naturally only going to make so much. plus you've suppressed yourself for a given a number of times. So, you know, whatever levels you would have had you never taken TRT, now that you're in shape, we're probably going to wind up being less than that because you've been suppressed. Yep. So to say, well, I'm going to get in shape with everything, now I'm going to get off my testosterone, personally, I wouldn't do it. I'd be like, you're in shape, you've got muscle tone, you've lost body fat, your libido's back to normal, you're breathing better, you're exercising, you're, you know, 35, 40 years old, stay on the testosterone. Don't say, let me stop this now and let me see if I can restart my natural production, because there's a very good chance that you actually regress, if anything.
Yep, I agree.
So.
Yeah, I don't see a likelihood of that. Now, some guys, it could bounce back. I mean, why would you want to live through that hell of however 6 months to a year trying to figure that out? Or some guys will come off and then get on Clomid and do all this stuff and they feel like crap. That's fine if you really want to try to permanently get off because you just hate it. But otherwise, if you feel good and you don't mind being on it, you don't need to come off. You're dialed in, you're good. I mean, just roll with it. Like I tell people, it's just part of your life. You just take your testosterone and go about your day. It's not, you don't even think about it. So
there's one I'll touch on that, Jordan, you said that it's not really something that maybe that you do a lot, but he did make it sound like optimizing thyroid is in most cases unnecessary. You've probably seen in the group how many guys have been on TRT, tried a number of different protocols, nothing seems to work. Doctor says my labs for thyroid are normal, so I know it's not that, and they're just going on and on and on about everything else that they're trying and nothing seems to work. And some of these guys will be told by a new doctor, let's try a trial of thyroid regardless, just as we can potentially try a trial of testosterone. If your labs are normal, but you have all the symptoms of low testosterone, we can add testosterone. If you feel better, great. If you don't, well, then it wasn't the issue. The same thing applies with thyroid guys. If you have got symptoms of low thyroid, but your labs are normal, you can still try thyroid. And what I see a lot of, and Jordan, you're going to potentially chime in on this, is so many failed TRT protocols where guys aren't really feeling the way they should. And then they say, well, let me try thyroid for a bit and I'm just going to see if it makes a difference. And some of them come back, it's like, I can't believe the difference it's made. I'm finally feeling all those things that I thought TRT was going to bring me from day one. I'm feeling now that I've got thyroid brought up. Is that something, anything you want to chime in on there?
I see it. I see guys talk about it all the time. Like I said, I don't do it as a urologist, so I'll plead ignorance on it, but I'm fascinated by it and I have no problem with it because I totally don't think that labs tell the story on most things. So if somebody's got the symptoms and and they try a trial of T3 or T4, T3 combo or whatever it is, and they feel better and they're not being harmed by it, they're not having side effects, they're not having palpitations, they're not having any blood pressure issues, anything weird, I don't see a problem with that. I know there's controversy around the country of people being placed on thyroid when they had normal labs. Apparently that's a really big deal, and I'm not exactly sure why, other than certain doctors want to keep a hold of their little niche and don't like giving it over to other people. But anyway, but I can't say much about it. But I have no problem with guys trying to optimize their thyroid. I mean, we need to all try to optimize our health, and sometimes staying within the system, what the system has been, told you to believe and feel, it's not always right. It's usually not, unfortunately. I mean, a lot of this stuff's just guidelines, but the people who sometimes do the self-experiments and who figure this stuff out are actually right, and they're ahead of the science a lot of the times, but that's all I got to say about that. Yeah, I don't do thyroid replacement, and so I'll plead, I'll defer that to the experts that do it. But I know plenty of doctors that we've talked to that do that treat based on symptoms, and they do optimized thyroid, and they get results from it. So, yep.
He was also mentioning that he just measures TSH. Guys, if you're going to get thyroid done, at the very least, TSH, which is thyroid stimulating hormone, free T3 and free T4, at the very least. Just measuring TSH isn't going to paint the full picture. Even if you have all three, it's still not going to paint the full picture, but you'll have a hell of a lot more information than just TSH. We just did a video about this recorded right before, but he claims that he wants to do responsible TRT. So he says, I want to do responsible TRT. But he blocks estrogen. He claimed that estrogen is related to inflammation. He said that I don't know if you saw that part of the transcript. Mm-hmm. And he said that he measured the bone mineral density of a guy that had been on an AI for a few months and saw no real difference. You want to start with that one?
I mean, I would honestly refer them to the estradiol Broscience video that we just recorded, which should hopefully be out tomorrow, because it'll probably cover all of that. And I would say if they have any questions or issues, at least watch that and be open-minded and read the actual papers that deal with estradiol in men, not these association studies that people base this stuff on, not synthetic non-bioidentical estrogens, none of that. I would definitely say, and this is not just to him, because this is the majority, I would think, of TRT providers, it is irresponsible to be giving men aromatase inhibitors. I will say that. I'll come out and say it on record. If I'm shown to be wrong one day, I will gladly retract it. I've seen no studies showing benefit from them and that they're needed, and lots that show harm from aromatase inhibitor use, not just with worse symptoms, but with health detriments. And the bone mineral density thing, you're not going to see it after a couple months. It takes time to see that. And that's been mentioned in several of these studies dealing with aromatase deficiency in men and their bone mineral density and all that. And we have papers on that too. So I'd just leave it at that. I think that we've covered estradiol, and we've got the video we just did a few minutes ago, I think should cover a lot of that for sure.
Yeah. So I won't go too much into detail, but guys, there is literally no evidence out there that estradiol should be blocked when you're on TRT, okay? When you have sufficient levels of testosterone and you got sufficient levels of E2, you're good to go. You do not want to block it. There's no studies that talk about, we did this study, we brought up a man's testosterone levels, but then we gave them an AI. Like, we don't have any of that, okay?
Well, they do have studies where they've done both, but they haven't shown that the guys with the AI felt better or did better.
Right.
It was the opposite, right? That they needed the AI, correct?
Exactly.
Yeah.
And he's saying estrogen is related to inflammation. I mean, we've seen all kinds of weird associative studies about,
right,
especially with prostate and whatever else that's been debunked, like with ease.
Or it's not physiologic. It's not meaningful in a physiologic context of what we're talking about. It's some either cell study or they're using a different kind of estrogen. It's not aromatized estradiol. Yeah,
exactly. This particular one really blew my mind. I actually had to pause the podcast and I giggled like a schoolboy, I think for 10 minutes, because I couldn't believe that this was being said in a public space. So you have to excuse that I'm being colorful here, but this was a mind blower to me. This particular guy who owns clinics, he's not a medical professional, not a doctor or a physician, which is funny because he was challenging anybody who would comment, challenging his position, saying, well, what are your credentials? Are you a physician? Are you a medical? And he isn't himself. So it seems to me that he and I are both equivalent. Neither of us has any medical training. But he, in his practice, tends to use the cream versus injections, and made a claim that if you take the cream, it does not suppress FSH or LH. Can you explain to me if that is even remotely possible, Dr. Grant?
It's possible if one were to use a very small amount intermittently for a very short period of time. Once you're using the cream for, I don't know, a couple weeks, it's going to be pretty steady state. The cream is not like natural testosterone. Natural testosterone can be up and down within hours. That's not how cream works. I've got lab work on guys who are only on a once a day cream application in the morning, 2 or 3 clicks, and by the next morning, their levels are still pretty impressive. It's not natural. You're not mimicking the natural pulse of testosterone as a lot of people claim with the cream. And so no, any sustained levels of exogenous androgens or estrogens, either one, will affect the negative feedback loop and shut down LH, FSH production.
So if you were taking a tiny little bit of testosterone a day, like just a little whatever, it might not suppress you.
One dose of cream, no, one dose. Now you could probably do a big bolus of an enanthate injection or something like that. I mean, I know with one dose of nandrolone, DECA will shut you down right away because it's long acting. You know what I mean? One dose of cream, though, no, but they're not doing one dose. They're doing daily doses or probably twice a day doses for at least 6 months until they do their little break. And so, that's going to shut down the hormone, the LH, FSH, which is fine. It's not a big deal. I don't know why anybody would be concerned about that.
The argument was the cream will not shut it down. Injections will. Guys, you want to finish your sentence? Okay.
Yeah, I mean, it's just not true. I don't know what else to say. I mean, I got blood work, and I don't check LHFSH on guys on TRT because you don't need to. It's going to be less than 0.1 on all on the labs. But I've seen it from other providers who maybe had somebody on cream and they're still checking that for whatever reason as a click box on their labs. It's less than 0.1. I mean, it's just going to happen. I mean, would you ever tell a guy who's getting on cream he doesn't have to worry about fertility and all that because his LHFSH isn't going to go down? No, I doubt that, So.
Guys, at the end of the day, simple English, it doesn't matter what method of administration you use. You can use pellets, you can use cream, you can use injections, you can use a nasal spray, you can use a sublingual, you can shove it in from whatever angle and orifice you want. If you are taking in testosterone from an outside source and putting it into your body, think of your body as a thermostat. Okay, it's going to say, hey, I've got levels. I don't need to make any. There's plenty of it here. Yeah. Your natural production is going to get shut down. Okay, so if anybody's telling you, oh, with the cream it's fine, you won't get shut down. No, that is absolutely no. You're going to get shut down. End of story. I don't care what method you use. As soon as you start taking testosterone, you will get shut down. Okay,
pretty soon. Yeah, it's. I mean, there's a complex mechanism responsible for it. It's it doesn't matter though how it works. That's how it works. And I will say this is a tangent, but HCG also shuts down your LH. Mm-hmm. Okay, guys think that it resets it. It doesn't. It suppresses it.
It acts like it.
It acts like it, but it's not LH. Even if you took LH, if you took actual LH, that would shut down your body's own. These are tightly controlled negative feedback mechanisms. So a lot of these guys, when they say they're taking HCG to restart their LH production, no, you're not. It's not working. Clomid may do that, yes, but not HCG. So anyway.
So guys, just a simple analogy you can wrap your brains around it. Imagine your natural production of testosterone was the heat in your house, right? So you got a thermostat, it's wintertime, you turn your thermostat up to a certain amount, and if your temperature falls below that, your heaters are going to kick on and it's going to produce heat, right? Now let's say you got a fireplace like I do over here, and you turn the fireplace on and the fireplace is generating heat. Well, what happens? Well, now the heat, you're always going to have ample heat. Those thermostats are never going to kick on, ever. Your heaters aren't going to work because it's getting heat from somewhere else. It's getting heat from the fireplace. So they're just never going to kick on. And eventually they just die out, right?
They decrease. I mean, it's a little more complicated than that. I mean, there's a reason that if you're on long enough, things don't rebound because those cells aren't doing what they're supposed to be doing. And not just the cells up here, but in the testes as well, Leydig cells and all that. So both are getting affected. Yeah. But yeah, I don't understand. I don't understand what he's saying. I mean, I guess the only way theoretically you might be able to pull off not shutting down LHFSH would be like a testosterone suspension injection once a day, because it's even then I think it might last long enough in the blood to shut you down, but it's gonna still, But the cream, no. And I think you were going to bring up the application sites of the cream.
Yes. Well, so. Yes. Claimed the scrotal application of cream doesn't work. How many guys do we have in our Facebook group on the scrotal application of cream with levels through the stratosphere? And why is that? The scrotal application has 8 times greater absorption in that particular spot than anywhere else in the body due to the thin skin. There's a lot of 5-alpha reductase in the scrotal skin, which means that some of the testosterone gets converted into DHT. DHT being kind of a feel-good hormone. It's also anabolic. It also helps to drive some libido. Some guys do great with these added levels of DHT. That's what they do better on the cream. Others don't. They maybe prefer injections. But the scrotal application is known as the place where you can apply the tiniest amount of cream and get the most amount of benefits. On top of that, he was making it sound like, oh, I won't put cream down there. Like, what side effects is it going to have? It's not the testicles that is absorbing the cream. Okay, the cream isn't affecting testicles. The cream is getting absorbed by the scrotal skin. It's a very, very thin skin with there's a lot of blood vessels around it, and it's a delivery system.
Yep.
Okay. You do scrotal application for cream in your practice.
You'd be amazed at the difference I've seen when guys come in doing 8 clicks to their shoulders and their levels are 500. And I go, hey, do 2 clicks to your scrotum and let's check some levels. And then they're 1200. I mean, literally. Right. And that's, you know what that is? That's a huge cost savings for the patient, because cream is not, it's cheap for medicine, but it's still an expense. And it's right. $50 a month, 50, $60 a month for some of these guys. And if they can get by with doing two clicks twice a day, or 2 in 1, you know, something like that, it's a lot better than going through 2 canisters a month of this stuff, which some people do. And again, maybe I'm missing something with what he said, or he could maybe explain it a little better, because I didn't feel like it was explained as to why not do the scrotal application.
He said the levels are very inconsistent. There's too much variation. They're all over the place. Patients were complaining that they're up and they're down and this and that. And it's like, everyone we know is with the cream is doing scrotal application. Yeah. And
there's a couple guys in the group that decided they got too amped up from it. And so they did do like top of the foot, back of the knee. But I mean, I saw their blood work differences. They're not that different. So I don't know if it was the DHT component, you know, maybe. That even the DHT wasn't that different, because I think they measured it. So, you know, that's fine if you feel better. But if you've never tried the scrotal, I would try it. It's not bad. It's an excellent delivery method. The scrotal skin is ridiculously vascular. Any of us who've done scrotal surgeries, urologists, know this. It means do a vasectomy and make a little stab incision, and it can bleed like crazy. I mean, it is that muscle, dartos muscle in there, which causes it to, you know, ball up when you're cold. You know, I was in the pool when it does that. That's that muscle. Well, that muscle's full of blood vessels. The skin is a different texture down there. We all, I mean, if you compare it, you know, we're all guys. You can feel the difference in that skin than any other skin. So it just absorbs it much better there. I think it's a fantastic way to apply the cream. So that's just. And
we do have literature. I did post one of the studies, and he was saying something about, these are guys. The study was done on guys that had done nandrolone and blah blah. It's irrelevant. The skin there absorbs 8 times more than anywhere else, and that's why we apply it there, because, you know, we don't want to be applying a ton of cream all over the place when we can apply just a tiny little bit in one place and get the same effect.
And you're less likely to transfer it to somebody else when you put it under scrotum. Yes. You don't have to worry about you're wearing shorts and is there still some left over on the back of my knee, or somebody come touch me on my shoulder, a kid or a woman. Most of the people like that aren't touching your scrotum, you know.
Yeah. So I'd love to know more what the reasoning was, because we've seen this over 1,000 times at this point. And I mean, we've got so many doctors on that use the scrotal cream. I've never done it myself, but I know guys that rave about it all the time.
I haven't done it myself either. I just have a lot of patients doing it, and we know a ton of our guys on the Facebook group and other Facebook groups. And I mean, it's very common now to do the scrotal cream. That's kind of a pretty popular approach, actually. So yeah, I was a little confused by that one.
Yeah. So I don't know if it's, you know, is it, I don't want to use the word ignorance, but it's just ignorance that he doesn't know any better? Or is it like, hey, I've got a clinic and I sell cream, so I'll tell them to apply it somewhere else, so they have to use so much more cream so I can sell more cream? Or what? I don't know what it is. It could be a number of things. I'd like to know why. But for someone to say that this application doesn't work, it's just...
Yeah, I don't want to speculate. On that side of it, I just would love to know more on a lot of this stuff. Maybe I think sometimes there's a communication breakdown, and you know, he's doing a podcast, and he's just, you know, you got to talk fast, and so that can always, you know, so maybe be good just to hash those things out and get a better idea of what's going on. We're not trying to knock the guy at all. Again, he's not doing anything honestly that different than a lot of people are doing, unfortunately. It's just unfortunate. It is ignorance, and that's not a bad word. Ignorance just means you don't really know. And until you do this stuff and you start really, really digging deep into it, you're going to still do just more of a fluff layer like a lot of clinics do. And when they deal with a high volume of patients, I get it. You don't want to always take the time to dial people in. I mean, I've got guys who are using telemedicine clinics, and they were telling me how they call and they can never talk to the doctor. They always get a nurse practitioner or a PA, and they just go, well, I'm having this kind of symptom. And you know what the first thing is they tell them? You need to take an aromatase inhibitor. They don't see anybody. They don't talk to a doctor. They just go, I'm just not quite feeling right, or blah, blah, blah. Yep, your estrogen. Oh, yeah, let's check your estradiol. Oh, yeah, it's at 50. Your total's at 1,600, but your estradiol is at 50. We got to give you an AI. And anyway, I'm not saying that's what this clinic's doing, by the way. I'm just saying a lot of clinics, they don't have the time, I guess, sometimes, or the resources to take the time to dial things in with people on a personal level. I think I have a luxury of being able to do that with what I do. That's why I like doing it, because I can spend 45 minutes with a patient and really talk to them about everything, and then follow up with them on the phone, or even, through EMR system or email or whatever, and we can talk. And I have time to do that right now in my life. And I do understand it's hard. And they're not doing anything crazy other than the restart. I will say the restart protocol every 6 months, if that's a standard thing, that's not standard. So I'm not sure about that one. But some of this other stuff, it's just, take the time, at least look into this stuff and learn it. I mean, the estradiol thing is huge. If more clinics, like I said, I don't have anything to gain financially by telling people not to use an aromatase inhibitor. I want everyone out there to be doing that, to not use it. If that keeps people from coming to see me in clinic, that's fine. I'm a urologist. Like, I have plenty of stuff to do. I love TRT, but if you can take care of these guys and they don't have to drive 8 hours to see me, because a lot of people will, or drive to see, Brad Garner in Missouri, or do telemedicine with whatever. If they don't have to do that, if they can go to their local doc because they're actually educated and they'll get a good protocol, that's worth it. Just do it. So that's what we're doing here, is we're trying to educate people on what to ask their doctors. We're educating the people that take testosterone, but we want the physicians, the PAs, the NPs, and the clinic owners and all this, start learning this stuff, because it's a big deal. And I have learned more in the last year than I had in 4 years of med school and 5 years of residency, just by dealing with these patients on a personal level, and by joining the Facebook groups and talking to more guys around the world, not just the country, but the world, that there's a lot of people in the same boat, and they're all on these cookie cutter protocols, and they never feel dialed in. And there's a reason for that. And once you start figuring out what those reasons are, it's really easy to get guys dialed in. Testosterone replacement is not rocket science at all. And so, sorry for that tangent. Like I say, we're not knocking this one guy. This is common stuff we see, but I think it does need to be called out when it's said. And I think people who are truly willing to learn will maybe at least look into it and go, you know what? Yeah, they're right. It does, testosterone, it does suppress LH, FSH. I really should, and if they're not willing to do that, then I do question the motives. And I'm not saying I'm questioning his motives, but I do question it when people aren't willing to look. I was kicked out of a recent Facebook group because I dared to question somebody on the high hematocrit leads to thicker blood hypothesis. And all I did was say, hey, there's some actual studies by trauma surgeons and trauma researchers where giving blood and leading to higher hematocrit actually causes lower blood pressure. Like, that's all I said. Like, there's other schools of thought out there. I kicked out for that. And that there's an agenda there. If you're not even willing to look at it and go, hey, that's interesting, let's talk about that, and just go, no, you're gone. That's when I worry about these people, if you got an angle. So don't be like that, you clinics out there. Don't do that. Don't have an angle. Just do what's right for the patient. And if it's not right to give them aromatase inhibitors, stop it. Stop selling it to them. Stop buying it from the pharmacies and getting it in and selling them to people. Stop it. So,
Absolutely.
Stop.
Guys, really
like
quick.
Bob Newhart here. Stop it. Just stop it.
I was gonna skip that one point you just brought up, but now you brought it up, and now I have to say it. Okay, the whole issue of hematocrit and hemoglobin. There's doctors out there that are monitoring this stuff down to the thing, and they're like, "Oh, you're too high, you got to go get blood. Oh, you're too high, we got to lower your dose. Oh, you're too high, we got to do this." Okay,
take you off. Yeah,
your high levels of hematocrit and hemoglobin are fine. When they go up, when you're on TRT, guess why? Because that's how it works. You take testosterone exogenously, your hematocrit and hemoglobin will go up. Some people will go up higher than others, okay? What you want to monitor is platelets. If hematocrit and hemoglobin are up and your platelets are like normal, whatever, you're fine. There's athletes out there that are taking things like EPO to basically jack up their hematocrit and hemoglobin. Why? Because then you have much better oxygenation of the blood and you have better performance. Offline, Jordan was even talking about he's seeing studies of higher levels of hematocrit hemoglobin actually lowering blood pressure. He was just bringing it up here. So it's not something you got to worry about. It's called erythrocytosis. Okay, erythrocytosis, completely normal. It's completely to be expected. We see labs from guys all the time in our Facebook group. And they're like, "Oh, my hematocrit's at 55 and my hemoglobin is here." I'm like, "How do you feel?" "Feel great. Everything's fine. No symptoms. No symptoms. You're fine." If platelets start going up and jack up along these higher levels, that could be a sign of something dangerous called polycythemia vera, which is essentially a cancer of the blood, if you will. That is something that is serious and definitely needs to be addressed. Okay, erythrocytosis does not need to necessarily lead to polycythemia vera. If you just have erythrocytosis, high levels of hematocrit hemoglobin, you don't have to go donate blood all the times. Okay, there's athletes everywhere that are having these higher levels. They're not donating blood. People that live at altitude that have higher levels like this, naturally, they're not having to donate blood. Yes, the argument can be made, well, they've been living at altitude for so long and their bodies have adapted and so on and so forth. We're just not seeing this in practice. And I've asked a number of physicians, what is your number at? Where do you cut it off? When the hematocrit gets to 55 or 56, it's always around there, and they've never quite seen any higher. And one physician told me, he says, I've seen guys as high as 57. Yeah. They were fine.
I have seen a guy who was 60, but he wasn't on testosterone yet. He had COPD. He's very unhealthy. So yeah, those guys I would be very hesitant to start on just because mainly liability purposes.
Well, there's a pre-existing condition.
Yeah, absolutely. And I will say this: my mind is not made up 100% on the hematocrit thing. The evidence I'm seeing, though, when people start to truly look at and they tease it out, and because this is the same issue with estrogen, people aren't looking at the right thing. If you start looking at actual studies, and so far they're really only doing them on mice, like, okay, let's really see what blood viscosity does when we put this rat on testosterone. Like, we want to see what secondary erythrocytosis from testosterone causes. What they see is no change in major viscosity. One study showed lower blood pressure, not higher. The body, and it took about 6 months. It seemed like in the first 6 months there was an increased viscosity, and after that the body accommodated and everything went back to normal. So could there be a window there when you start TRT, if you're prone to a really high hematocrit, or if you, let's say you already have it, could there be a window of risk? Maybe. I don't know. There's really nothing definitive, and that's what makes me angry is that all these guys that say you're going to drop dead tomorrow of a stroke. No. You don't know that. There's no studies showing that. Yeah, like you say, is there a cutoff? I mean, our lab around here, the high normal is 55%. Well, there's guys that get to 50 and they're told they're going to drop dead. Like, that's just, these guys are crashing their ferritin levels. I don't know how many posts I see with guys posting they're having high hematocrit symptoms. You know what their symptoms are when you start reading them? They're symptoms of low ferritin. And then you go get them and they check their labs and their ferritin's 10. Or 15, and it's like, maybe that's why you're short of breath. You really think you're that short of breath from an increased oxygen carrying capacity of hematocrit?
I know, it's crazy.
I mean, but crazy. They think, in their minds, they're thinking thick blood, so it's not moving. It doesn't. That's not how it works. So
the guy at a farm says you got molasses going through your veins. Like, no,
it's not quite like that. I mean, could there be a point? I mean, I literally saw, I think it was in the Andes, there's a group of people and their hematocrits are like 75 to 90%. Could that be molasses? Probably. Yeah. I mean, that's crazy. But a lot of the hematology journals, they don't really define it as pathologic when they were looking at the hemoglobin until the hemoglobin was over 21. So again, like, it's probably not as bad as people are making it out to be. And that's kind of what we want to stress. And I'm happy to say I don't know, and that we don't know for sure. But my suspicion is it's not as big a deal as people make it out to be. Could it be an indicator that there's something else going on? Yes. If you have an already high hematocrit when you're starting TRT, you probably are a smoker, COPD, sleep apnea is huge. Tons of guys, especially if they've gained some weight and they're bigger, they got bigger necks, they've got sleep apnea, and they've got higher hematocrit. The high hematocrit is simply a response to the apnea. The apnea is the problem. Is that higher hematocrit going to cause an actual problem? Probably not. I don't know, but it's an indicator that something else is going on underneath. And that's something to be looked into. Like, I mean, and I've got tons of guys on testosterone, their hematocrits stay in the 40s, on injections even, It's very actually rare that I have a guy, I mean, less than 10%, I would say, of the guys on injections have a hematocrit over 54, something like that. The cream, it is less, it's more rare to see a really high hematocrit with the cream. Cream is just, and it's the same with daily injections. Anytime you're doing it daily, smaller peaks and lower, higher troughs, but smaller peaks. You're just down here every day, all the time. You tend to just be leveled out, whether that's with E2 or DHT or free testosterone. You're going to have a higher free T with daily application. And that's, with the cream, a lot of people, they say, well, my DHT is higher with the cream because of the skin. A little bit, but it's also because your free T is higher with the cream, and your free T is higher, and so you have higher DHT from that as well, or you just feel better because your free T is higher. They think it's my DHT, and not necessarily. You just got a better free T. I see crazy good free T levels with the cream. So anyway, I know that was a tangent, but the science is not settled, and that's what I want people to understand. It's not that science ever is settled, but on the high hematocrit thing, it gets really confusing because it's even smart people and doctors and researchers call it polycythemia. What does the word poly mean? Multiple cell lines that are too high. That's not what we're seeing. We're seeing one cell line, red blood cells, like high hematocrit, the concentration. Like, it's not polycythemia. And doctors know that because we learn this stuff in med school, and hematologists especially know it because that's what they deal with. So it does frustrate me when they call it polycythemia, and then people start Googling polycythemia going, holy crap, this is dangerous. Well, yeah, polycythemia is dangerous. Do we know if secondary erythrocytosis from testosterone is dangerous? No, we don't.
Speaking of dangerous, I'll hit one last point, and I probably could have put this in a little bit different order, but when he was talking about the benefit of why he tends to use the cream more than injections, he said that most of his patients, they won't do injections. They're scared of injections. I don't know a bigger injection. I was going to say the P word, but I can only use the P word with Jordan Grant.
Yeah.
An injection weakling, if you will, than me.
Needle phobic.
Okay?
Needle phobic.
I was as needle phobic as they came. You would show me a needle, and I would just look at the needle and I'd pass out. Forget watching someone get injected. Forget injecting myself. And now I inject myself like several times a week, and it's no big deal. The majority of the guys in our group are on injections, from what I can tell. The rest are on the cream. Tons and tons of guys out there get injections. He says apparently his patients won't. Again, is it because he sells cream? I don't know. Again, I'm speculating. But he said, there's reason that we have evidence pointing to 300 milligrams of injections every 3 weeks causing cardiovascular disease. I'm not sure how testosterone causes cardiovascular disease, considering testosterone is cardioprotective. Thoughts, Dr. Grant?
Let's just break that down real quick and just let it sit, what you said. What was it again?
He said he had evidence of 300 milligrams of testosterone via injection every 3 weeks. First of all, I don't know who the hell would do that.
Well, there you go.
Somebody somewhere is apparently, according to him, 300 every 3 weeks, but causing cardiovascular disease.
No, it doesn't work that way. We've got plenty of studies showing testosterone is cardioprotective. You have lower incidence of cardiovascular disease. If you do have a heart attack and you're on testosterone, you're more likely to survive it. Guys with florid congestive heart failure, given testosterone, improves cardiac contractility. I mean, and this has probably been in the last, 5-10 years, but especially the last 5 years, it's nothing but positive coming out. Every now and then you'll get some really biased study because there's certain groups that just hate testosterone. But overall, it's, and most people are realizing this now, that it's cardioprotective. 300 milligrams every 3 weeks, you're literally castrating a man pretty much with testosterone. So you get him normal for, 6 days, maybe 10. And then the rest of the time he's low again. And so you're doing this. He's got low T more of that time than he's high T. So to say that it's the testosterone that's causing him to have whatever this study was, I don't know what it was, but
like 2 out of 3 weeks, 2 out of the 3 weeks, he would actually be deficient in androgens. That in itself could potentially make him sick.
You think? Yeah, you're low T and low E as well. So you're not getting the beneficial. I mean, a big part of the cardioprotection, the neuroprotection from testosterone is the estrogen, estradiol. That is what's actually protecting your endothelium. nitric oxide increase. DHT helps as well, but it's that the E2 is very cardioprotective and vascular protective, neuroprotective. So 300 milligrams every 3 weeks. And again, I see these protocols a lot. There's doctors here, there's doctors literally everywhere. Here, I mean, the United States, but all over the world I see this because I get messages from guys in other countries telling me about their protocol, and they're on 250 of sustanon every 2 weeks. That's like the standard European protocol. And we just tell them, hey, that's crap. I mean, it is. Every 2 weeks is crap. Once a week, in a few people, they can get by with it. Because I have maybe less than 10 patients that are doing once a week because they're like, yeah, I just got tired of doing twice a week and I did once and I still feel fine. Hey, there you go. You feel great. And
do that.
Because it's about them. It's not me going, well, that's not right. You got to do it twice a week, you know.
But that's what, 5 to 10% of guys that are really going to do well on once a week?
And for whatever reason, they're fine with that because they're not burning through it. Maybe they're not really low SHBG guys, and so it's not a big deal. They have a higher SHBG to kind of time release that testosterone. And because I've checked their troughs after a week at the end of the week, and they're still decent. You know, they may still be 800 after 7 days, and they feel fine, whatever. Most guys are on twice a week. Anyway, I don't know where I was going with all that. 300 milligrams every 3 weeks. I've seen 400 milligrams once a month. It's not. The
first endo I went to see told me you're going to take 400 milligrams once a month. And I said, you should be fired on the spot.
It's bad medicine.
This is borderline criminal. I told him to his face, what you're suggesting is borderline criminal.
Yeah, it's literally castration with testosterone. Yeah, is what that is. And,
so I don't know if this guy was comparing the cream being better because comparing it to 300 milligrams of injections every 3 weeks.
Well, sure.
Yeah, probably applying the cream on my nose. And again, I could probably apply it a lot because I've got a huge one. But that's besides the point. But I'd probably get better results than taking 300 milligrams every 3 weeks.
Yeah.
But you can't. It's not exactly a fair comparison. It's a good way to sell cream.
Yeah.
Try getting a guy on injections twice a week, or
injections
a day or
cheap.
whatever. Yeah. And they're cheap, much cheaper.
Yeah, I mean that's why a lot of my guys are on injections. When I mention the cream and I tell them it's $50 a month, they're like, "Well, how much are injections?" They're like, "Well, on average, maybe $20 a month." You know, and they're like, "Okay, I'll do that." You know.
Yeah.
That's what I do. I mean, here it's $53 for a 10 cc vial with a good RX coupon. I mean, I've seen some guys getting cheaper than that. That'll last you 9 to 15 weeks, depending on your protocol. You know, maybe shorter, 8 to 15, depends on how much you're taking. Anyway, yeah, it's not a fair comparison. So I don't, there's more to it. Maybe it's just patients just don't want to inject themselves. The patient population they're seeing maybe are a different kind of patient population that are scared of needles, and I don't know, but it's not a big deal. I mean, at least you're helping people. That's fine, but there's little tweaks that can be made here, in my opinion, that at least give people an option, I think, of injections, because not everybody does respond to the cream. I know that some people think that everyone who uses it will respond. It's not true. There are differences in some people's skin. Some people do the cream and just don't like it. You know, they don't want to have to do it every day. I don't want to have to do it every day. That's why I didn't do it. And some people don't like the residue it leaves behind, even if it's just minimal. They're just like, they don't like it. That's fine. It's personal preference. You know, give people the option. It sounds like they at least give them the option of injections, I hope. Injections are fine. They work. They're tried and true. They're going to be around for a long time. You're putting a depot in the muscle. It's going to work. It's going to absorb. You know, It's just a matter of getting the right frequency and dose in, but that's easy. It's not a big deal.
So anyway, those were just, again, a few points I took out. There were a lot more that I wrote down, believe it or not. I think I crossed out like half of them just for the sake of time restraints. I didn't want it to get overly long because I think we could have talked about some of the points for like hours on end. Ben Greenfield. If you happen to watch this and you'd like to have Jordan and I, Dr. Grant and I on your podcast to kind of refute some of the stuff that's being said, we absolutely would. If you'd like to come on this show at one point, we'd love to have you as a guest.
Yeah,
something you'd like to talk about. But I can't. Jordan and I are passionate about one thing, and we get angry about one particular thing, and that is misinformation. It's demonstrably false, demonstrably inaccurate information. Other than that, we're the greatest guys in the world. But when we see bad information that could potentially send the guy down a wrong path, this protocol, I mean, you should see Jordan's face get red in some of these podcasts we do. He gets beat red. And I'm the same way. I'm Italian and hot-blooded. I just want guys to feel good. I want them to be healthy. I want to get the best information. I got nothing to sell you. Hopefully, some of the stuff that we're doing helps you guys out. Whichever doctor you use, whichever method you use, I don't care what it is. You're taking pregnenolone, you're not. Maybe you're on DHA, you're not. If there's something that we've said that has helped you in some way, we're happy. That's it. That's pretty much where it ends, all right? So, again, we're going to be having Dr. Grant on again for some other talks. And Jordan, thank you as always for coming on.
Yeah, I appreciate you having me. And like I say, I don't want this gentleman to think we're calling him out specifically, because he's not doing much other than the restart, much different than a lot of providers are doing. And that's what we're about. We're not just knocking him. It just happened to be on this podcast. We need to talk about it. It's a good way to actually bring up these points, but this stuff needs to be addressed everywhere across the world. Just get guys dialed in a little better, try to focus on the science behind this stuff. And I think you'll reap rewards, because you'll have happy patients. And that's what you really want, is people to feel better. So
it's like you're saying, there's physicians everywhere that are doing this kind of thing. We know it to be wrong. But sometimes they're doing it in the privacy of their own practice, whatever, and we don't really hear about it. But when I see it posted in a public space, or in a video, or in a vlog, or in a podcast, or whatever, they're basically putting out for all the public to say, this is best practices. And I'm like, no, it's not. We've done this. We've seen this. We know this doesn't work. We've evolved to these things for these reasons. He even suggested, he sent me a message on Facebook saying, we can have a phone call and I can demonstrate to you why I'm correct. There's nothing he could tell me that would prove that taking exogenous testosterone as an example will not suppress LH, FSH. It's biology. It just doesn't work that way. It just doesn't. Yeah. There's points here that.
Yeah, there's a few things that need to be. I think there are a few points that maybe we just misunderstood, and I think just like is it permanent or not? Is TRT permanent or not? Maybe we misunderstood that, because I would think most people know that it is. So yeah, I think there are points of clarification. But yeah, I agree. There's a few things that are just kind of like blocking estradiol. It's, again, watch the video that we just did, make up your own mind on it. We'll link as many papers as we can before that video is posted. Make up your own mind and do the research. But when you do research, be careful what you look at. Don't look at studies that are not useful, that don't have relevance to what we're talking about. Don't just Google the word estrogen and then just start hammer posting stuff, or hematocrit. So,
yeah.
That's all I got.
Good. Thanks, Jordan. Appreciate it as always. All right. Have a good one.
You too.